Good afternoon everyone. This is Dr.M.Bhavani Shankar. I am working as an interventional radiologist in Anu Hospitals and recently associated with Imperial Hospital as visiting consultant. So as sir said, I make sure that I don't take much time. So I will try to finish in as early as possible, and I will try to discuss only the important points. So my topic of discussion is today HRCT patterns. Apart from radiologist, in clinicians particularly in emergency situations and for basic interpretation, what should they know. So these are the points I am aiming to discuss. So the topic of discussion mainly basic anatomy and some disease patterns I want to discuss today. So you all know we have 2 lungs, 3 lobes, 2 fissures, one time, and 1 fissure and second left side, and there are so many segments. These things everyone might know. So these things I will discuss in the radiological aspects. How to read film, HRCT film, and how to read some basic patterns and all. So both lungs on right side 2 fissures are there, major fissure, minor fissure, and left side 1 fissure will be there, minor fissure, and mostly major fissure divides upper and lower lobes on right side and both sides, and minor fissure divides upper and middle lobe on right side. And so on CT, the major fissure usually seen in axial and sagittal planes, and in CT we have 3 planes: axial, coronal, and sagittal. So this is the sagittal plane, and these are the axial images. So this is the normal lung window. So to read normal basic lung pathology, this window will be helpful. And these are mediastinal window. So this is mainly for to look for mediastinal structures like vasculature, lymph nodes, and to see any upper abdomen structures. This is the mediastinal window we used to call. So these 2 windows, one is lung window and one is mediastinal window. And in lung window, this is the sagittal plane, and another one is axial plane. So in sagittal plane, this is the major fissure on right side which divides upper and lower lobes, and this is the oblique fissure or minor fissure which divides middle and lower lobes, and on left side only one fissure which divides upper and lower lobes. And this is the coronal view. To see for coronal view separates the middle and lower lobes. This is showing the oblique fissure here. And in this is the rarely will find azagus fissure. This is not any abnormal. This is anatomical variant. This is normal only. So these are the axial sections. This is the coronal section, and previous one is sagittal section. These 3 planes, in any kind of CT, any kind of MRI, these 3 planes will be there. And in this is the normal division of our tracheobronchial segments. Like right side we have 10 segments, and left side we have 9 segments, upper lobe 3 segments, middle lobe 2 segments, basal lobe 5 segments on left side, and 4 segments on 5 segments on right side and 4 segments on left side. Except medial basal, all segments will be there. So this is the normal anatomical division: upper bronchus, middle bronchus, lower lobe bronchus. Same like upper bronchus, lingular bronchus, and basal segments bronchus. So in CT also we try to correlate with these two with like normal HRCT. So that's why that's how we actually divide the segments in HRCT. So I am not going into that much detail. So these are some basic axial sections of HRCT. So apical segments, especially like where actually the central one is trachea. At the level of trachea, you used to see only right side upper lobe and left side upper lobe. So once the trachea gets divided into carina, this is the starting of division of trachea into carina. At this level, this fissure will start. So this fissure is the major fissure, and I already told that it divides upper and lower lobes. Major fissure divides into upper and lower lobes, and once the carina divides and secondary division of bronchus starts, then there comes the every segmental bronchus, and that's how we used to read segments. But I thought that much depth regarding anatomy no need to discuss, I feel. So I just discussing basic lobes, and these sections especially at the level of heart, at the level of pulmonary trunks, at the level of heart, you will see on right side, this is the right side, this is the middle lobe segments, and if you carefully see, this is the minor fissure I told. So this is so on left side, corresponding to middle lobe, lingular segments will be there, and this basal portion will be entire left lower lobe. So this is how grossly we divide right upper, middle and lower lobes, and left upper, lingular and lower lobes. So these are all lung windows, and this is the mediastinal window. This is actually a contrast study. So this mediastinal window helps to discuss about, helps to read about the mainly vasculature, trachea, esophagus, and any upper abdominal structures, and any old heel granulomas or calcifications in the lungs, and any calcified masses. Apart from the regular core part, we used to always look for side wall, like chest wall, anterior chest wall, bones, and these things also we have to see. So in prevascular space, this is the remnant thymus. So this is normal aorta, and basic structures, this is the right ventricle, left atrium, right atrium, and this is the descending aorta, basic side, and while going down you see only ventricles, and then IVC drains into right ventricle. So this is the right ventricle, and almost at the end of heart sections, then upper abdominal structures will start to come. So this is the liver portion. So majorly pulmonary arteries. So this pulmonary arteries, left side pulmonary artery, this is the right pulmonary artery, this is the left pulmonary artery, this is the main pulmonary artery. So always in especially contrast studies, especially if you suspect some thromboembolism, make sure that there should be no major pulmonary artery thrombus, because major pulmonary artery thrombus is always life and death matter. So the contrast study major pulmonary arteries, and then basic heart chambers, right ventricular hypertrophy, left ventricular hypertrophy, these things are you can look for. So this is the normal mediastinal window, and showing vascular structures, and in this precarinal space, this prevascular space, this aortopulmonary window, all if you suspect, if you have any malignancy cases, or if you have any suspicion of mediastinal masses, they always look for mediastinal nodes enlargement. These spaces especially they will show the enlarged lymph nodes. So this is the coronal section, again showing the same structures like aorta and these three vessel arch of aorta. So this is the trachea, divides into right main and left main bronchus. These are the sagittal sections. This is the arch of aorta and descending aorta. These are the some structures. So this is coronal, and these are the sagittal planes. So this is normal basic anatomy and basic windows, mediastinal window, lung window, and what are the normal anatomical structures. We have to see important structures, and then comes basic disease patterns. So always in HRCT in lung window, so mainly two patterns. One is increased attenuation and one is decreased attenuation. Attenuation means the film you see there, that attenuation is increased or decreased. In increased attenuation, there again some patterns will be there, like reticular opacities, nodular opacities, and homogeneous kind of opacities, and which again divides into ground glass opacities and consolidation patches, and a decreased lung attenuation and bronchiectasis, air trapping, and mosaic attenuation and perfusion. So these are the overall disease patterns, and I will show them, and what are the some common disease conditions which can show these patterns. So coming to increased lung attenuation, first reticular opacities. So reticular opacities, see, lung is always made up of interstitial network fibers. So whenever there is accumulation of some fluid, some cells, some fibrous tissues, and some other materials, this interstitium will get thickened and appears as a linear and reticular opacities. So linear and reticular opacities, if you carefully see, so these are all the thickened interstitial septal thickening. So based on how the thickening will be, some disease conditions will be there. So the thickening should be the thickening should be either irregular thickening and smooth thickening, and sometimes nodular kind of thickening will be there. So the nodular kind of thickening, especially if you see, this is the some nodular septal thickening, and this is some smooth septal thickening. So the nodular septal thickening usually presents in some conditions like sarcoidosis and these things. And in smooth thickening, especially thick septa predominance, mainly one of the most common causes is pulmonary edema. So the pulmonary edema associated with thick smooth interstitial septal thickening are associated with pleural effusions. And another one is linear reticular opacities, irregular manner, some like just like scratches, these things will present in sarcoidosis, asbestosis and all. So based on low predominance and distribution, we will again divide sarcoidosis and asbestosis. So from this side, the take home point is pulmonary edema. Pulmonary edema is commonly present as smooth interstitial septal thickening associated with bilateral pleural effusions and cardiomegaly. This is one of the most common condition you came to see. And another one is parenchymal bands, like linear and reticular opacities, some parenchymal bands will be also present. So parenchymal bands sometimes associated with malignancy also, sometimes TB, old TB, again occupational lung disease like sarcoidosis, asbestosis, silicosis and all. So this how normal parenchymal bands, normal parenchymal tags will be appears. And in silicosis you see basal predominance in asbestosis, upper lobes predominance, and idiopathic pulmonary fibrosis like interstitial lung disease, again upper lobe predominance, and TB always apical segments predominance, like an NSAP, non-specific interstitial pneumonia, another kind of interstitial lung disease. This is also having basal predominance. So these basal parenchymal bands will come in these kind of diseases. And another is intralobular interstitial thickening. So basic difference is interlobular is always comparatively little central, whereas intralobular comparatively relatively peripheral and basal distribution. So normal fibrosis and septal thickening, I have already mentioned some basic disease patterns, and ground glass opacity is associated with interstitial septal thickening, crazy paving pattern. So this got familiar with our recent pandemic like COVID. So these are the normal some interlobular septal thickening presents as basal and peripheral reticular opacities. And honeycombing. So honeycombing means small cystic spaces with thickened walls composed of fibrous tissue arranged in clusters like grapes like manner. So this subpleural honeycomb cysts occurs in many conditions, but this should be differentiated with paraseptal emphysema that I will discuss later. So this honeycombing always represents the end stage disease regardless of the cause. That means that part of the lung is gone. So functional lung is gone in especially if you see honeycombing, and most commonly you see in idiopathic pulmonary fibrosis like interstitial lung disease. So these are the some distribution wise. Honeycombing it presents subpleural posterior location, most commonly associated with collagen vascular diseases or asbestosis and all. If upper mid lung and peribronchial predominance, sarcoidosis, chronic hypersensitive pneumonitis. And along with honeycombing, some if you see some nodules, cysts, consolidation like atypical findings, mostly you see in interstitial lung disease. So this is how we should differentiate paraseptal emphysema and honeycombing. So paraseptal emphysema usually comes in one layer kind, and there will be always associated emphysema, and I will show how emphysema looks on lungs, and it's always mostly upper lobe predominance, and the size is always more than 1 centimeter, and overall lung volume is increased. That means emphysema means hyperinflated lungs, so overall lung volume is increased. Whereas in honeycombing, usually I told you like a cluster of grapes, that kind multi layers will be there, and always it's always end stage process. So that means there is some previous insult, and that leads to further damage. So that's why fibrosis, some traction bronchiectasis, these are all always end stage findings, and this is mostly lower lobe predominance, and overall lung volume is here decreased. That means lung will be shrunken. So lobular, centrilobular opacities. So these are thickening of interstitium in some specific types like X shape, Y shape, dot shape. So these centrilobular, this is so close to the aortopulmonary window or this is the centrilobular distribution, and in peripheral are random and like multiple spaces. And perilymphatic distribution, one more important finding, this always in a linear pattern and always associated with this vascular bundle. So this perilymphatic distribution is also most common condition is lymphangioma, carcinomatosis and sarcoidosis. These conditions have perilymphatic distribution of these nodules. And random distribution, usually no definable distribution, miliary TB and all, you will see multiple centrilobular distributed nodules in the lung with no specific predominance. And centrilobular distribution, like close to this aortopulmonary window or bronchus, especially in silicosis or co-workers pneumococcal and lymphangitis spread of carcinoma. These are some conditions called centrilobular distribution of nodules. So one more is tree in bud appearance. So tree in bud appearance depicts impaction of bronchus, centrilobular bronchus, that small bronchus impacted with either mucus or pus or fluid, resulting in the dilatation of bronchus with associated other inflammation. So these dilated bronchus will appear as either V or Y, different shapes, but mostly you will see V or Y shapes. This finding indicates active ongoing pulmonary infection. So tree in bud in HRCT will looks like this, that is thickened bronchium with associated centrilobular, with associated nodules. So this pattern will give tree in bud appearance. So this indicates active spread of ongoing infection. So this is another cavity with associated consolidation patch, and these are multiple areas of tree in bud appearance. So this centrilobular distribution, tree in bud present, that means endobronchial spread of infection. If tree in bud absent, that is bronchial or vascular disease like invasive mucinous aspergillosis or aspiration, edema, hemorrhage and all. And in multinodular, that is random or perilymphatic distribution, if there is pleural nodules present, again we have to see the distribution, that if the perilymphatic distribution is there, sarcoidosis, lymphadenopathic carcinoma, and if is random distribution is there, again miliary infection, METs, hematogenous spread, and no pleural nodules, look for bronchial or vascular causes like aspiration, edema and all. So parenchymal opacification. So two patterns will be there, ground glass opacities and consolidation. So ground glass opacities presents ongoing active potentially treatable process. That means this is very recent infection, ground glass opacities indicates. So this is how normal HRCT will present the ground glass opacities, like some like white color patches, whatever you say. And difference between ground glass opacification and consolidation is the underlying structure. That means you are able to see some blackness or some vessels under these patches, that is ground glass opacification. If you are unable to see the underlying vascular markings and it's completely white, that is consolidation. So this is how consolidation looks, and that's how ground glass opacities looks. So ground glass opacity is associated with interlobular septal thickening, is one of the most common finding in advanced conditions. Like that means the interstitium of the lung is overfilled with some fluid or hemorrhage or some fibrosis, So this you can see in pulmonary edema also, and if you can see in pulmonary hemorrhage and some pneumocystis carinii or Girovici infections also, and ARDS, silicosis. These patterns you see crazy paving. This always represent some advanced disease process. So next comes consolidation. I already told you consolidation, obscuration of underlying air bronchogram, and it usually appears as white patches, and it depends on the distribution. Especially in COVID, we used to see basal and subpleural predominance distribution of consolidation patches in COVID, and in pulmonary edema there will be usually subpleural sparing will be there. And where these are all patterns represents increased lung attenuation. Now comes a decreased lung attenuation. That means the actual lung become more brighter something. So lung cysts, emphysema, bronchiectasis, these are the findings where the actual lung attenuation decreases. So lung cysts, so these are all some cysts this image showing multiple cysts in the lung. So common conditions like cystic mets, lymphadenitis, carcinomatosis and Langerhans cell histiocytosis, these are the some conditions and bronchiectasis, another common finding. It represents irreversible dilatation of bronchial tree. So there will be always like this one is small adjacent bronchus and this one is adjacent vessel. So normally this vessel should be more than this bronchial. So when this ratio is reversed, then bronchial or bronchus will be dilated, then you call as bronchiectasis. So this sign we will call as signet ring sign. That means just like our ring something. So this is dilated bronchus and this is small blood vessel. So this pattern will be reversed in bronchiectasis, and based on types of appearance there will be three types like cicatricial, cylindrical, varicose types and all. So ancillary findings that of bronchiectasis, that is mucoid impaction. So mucoid impaction leads to dilated bronchioles and air trapping. So due to mucoid impaction there will be air trapping, that means decrease lung attenuation, and again signet ring sign and bronchial wall thickening. These are the ancillary findings. So normal types, cylindrical. So this is the dilated bronchus. So depends on the shape of the appearance. So we used to label cylindrical, varicoid. So varicoid represents relatively advanced disease. And cystic bronchiectasis. So groups are cluster of cysts filled with air fluid levels. So presence of air fluid level. So this is the normal plain cyst. If there is any air fluid level presence, this means this is secondarily infected disease process. So traction bronchiectasis is usually associated with fibrosis, surrounding fibrosis, and overall lung volume will be decreased, and is usually end stage disease process. And another one is emphysema. So emphysema means abnormal enlargement of air spaces distal to terminal bronchioles. So there are three types of emphysema. One is centrilobular, paraseptal or panlobular. So centrilobular usually manifests as small air spaces or cystic air spaces, predominantly in the relatively central distribution. That this is centrilobular. And next one is panlobular. That means whole lung is decreased attenuation. So if you see here, hardly you can see any lung markings here. And another one is paraseptal. So paraseptal is always mostly around the subpleural location. So these are the some paraseptal emphysematous changes. So and it is usually mostly common in apical segments and subpleural location. So bullous emphysema is another entity. So if emphysema gets enlarged and forms large cystic spaces, that you call bulla, and bulla has any definitive wall, and emphysema more than 1 centimeter in diameter with less than 1 mm wall, and that means you hardly see any wall, but the diameter should be more than 1 centimeter, then you call bulla. So presence of large bulla is always risk for spontaneous pneumothorax. If they get rupture, patient may land into massive pneumothorax also. So then comes mosaic attenuation and perfusion. So basically mosaic attenuation and perfusion represents due to air trapping and bronchial there is a bronchial dilatation and overall decrease in lung attenuation. So overall entire bilateral lung mosaic pattern, one of the common condition you see is pulmonary embolism, acute and chronic pulmonary embolism. This is the one of the common condition where you see mosaic diffusely spread mosaic attenuation pattern, most commonly associated with pulmonary embolism. So these are inhomogeneous opacities, that is mosaic attenuation pattern. So mosaic perfusion, dilated pulmonary artery, vascular disease, abnormal airways or lobar lucencies, some airways disease like small airways or large airways disease. So vessels of uniform size associated with ground glass opacities. So you should look for ground glass opacities based on distribution and all. You have to differentiate from infectious cause. And one last slide, air trapping. So where are the obstructive pathology will be there? There will be definite air trapping, and air trapping you will see as decreased lung attenuation and overall mosaic pattern, mosaic perfusion will be there again. So either emphysema, COPD, asthma, some cystic fibrosis, bronchiolitis obliterans, these are all have obstructive lung pathology. So that leads to further overall increased lung mosaic perfusion. So with this slide I am concluding. So I don't know how but basic take home message is like basic anatomy, basic lobes identification, basic mediastinal structures identification. So normal common conditions like ground glass opacities or consolidation patches, main pulmonary artery you should able to see in, especially in suspicion of pulmonary embolism. Some normal honeycombing patterns and all, these are relatively advanced disease and disease process. So those are all most commonly seen in interstitial lung diseases and bronchiectasis, emphysema. I think these you can identify easily on the HRCT with this discussion, I think.